Hypertension is one of the most important diseases that we treat in clinics every day. However, there's not a lot of information out there on the exact pathophysiology of why hypertension is bad. Of course, we all know that hypertension is linked with things like atherosclerosis, aortic dissection, stroke, but there's not a lot of clear, concise information on how exactly it causes these things, and that's what this lecture is going to be about. My name is Chris, and I'm a third-year medical student, and this is a presentation that I put together that I presented to some of my peers, and I got really great feedback, so I decided to record it, and I'm going to post it on this channel. So hope you guys enjoy. All right, so in order to talk about hypertension, we must first establish what exactly blood pressure is. And you'd be surprised how many medical students actually aren't able to fully or completely articulate what exactly blood pressure is. Okay, so if you want, feel free to pause the video and take time to kind of come up with your own definition, and then we can talk about the definition that I found. All right, so the key is to not overcomplicate it. So remember from college, pressure is equal to force over area. That's quite literally the definition of pressure. So it stands to reason that blood pressure is force over area, but in our blood vessels, right? And if you want to get into a little more of a concise or meaningful definition, blood pressure can be defined as the force exerted by circulating blood on our vessel walls. Okay, so that's a great way to explain it to patients. Now, why do we have blood vessels? So remember that blood vessels are essentially pipes, right? And the purpose of blood vessels is to deliver blood to and from our body tissues. This makes sense, right? Remember, our body tissues, they're all alive, they're made up of living cells. They need a constant supply of oxygen, and also they need a way to remove certain metabolites and certain byproducts like carbon dioxide, right? So our blood is meant to act as this kind of conduit or delivery system to get nutrients to and from tissue. All right, so next up, why do we need blood pressure? And this will actually, the answer to this will actually surprise some of you. Well, the answer is we don't. We don't really need blood pressure, not directly at least. All right, and hold on for a second, stay with me. Okay, so this is a nice quote from Adolf Jarisch Jr. He was a famous cardiac physiologist or researcher back in the early 1900s. As a matter of fact, Jarisch's father, I forget his first name, but Dr. Jarisch was a dermatologist who studied venereal disease. And if some of you are familiar with the Jarisch-Herxheimer reaction, that was actually named after Adolf Jarisch's father, right? The Jarisch-Herxheimer reaction is, of course, the constellation of flu-like symptoms that you get after you use penicillin to treat syphilis. And the reason for that is because the penicillin is rapidly killing all of those nasty spirochetes in the body that's causing syphilis. And then this will cause those spirochetes to rupture and release different endotoxins and cytokines and result in this systemic inflammatory response that typically resolves within about 48 hours. That's just kind of an interesting little historical correlate. But anyway, here's the quote. So measurement of blood flow is so complicated, whereas that of blood pressure is so easy. Hence, the blood pressure manometer has exerted an almost hypnotic influence, though the bodily organs don't need pressure, but flow. All right, now it's starting to make sense, right? So we don't really need blood pressure directly. What you need to understand is that the most important function of blood pressure is to produce blood flow, right? And we've since discovered that pressure might actually be related to different complex mechanisms in the body that are needed to maintain homeostasis. But I mean, it's the general consensus is, of course, that the most important function of pressure is to just merely produce blood flow. That way we can get blood flowing to and from our body tissues. After all, that's the main job of our blood vessels. Okay, so next up, let's discuss what exactly drives blood flow, right? Here we have a law called Poiseuille's law. That's how you say it. Poiseuille, different people pronounce it differently. It's a French name, okay? And that law dictates that pressure is equal to flow times resistance. And you might notice that this actually bears an eerie resemblance to Ohm's law. Remember, V equals IR, voltage is equal to current times resistance, right? So this is somewhat similar. Instead, it's pressure is equal to flow times resistance. And the idea here is if you have a pipe, think any pipe, whether it's a real pipe or a blood vessel, if you exert a pressure differential across this pipe, it's going to result in flow, right? Fluids like to flow from areas of high pressure to low pressure. That's just how fluids work. It's a principle of fluid dynamics, right? And something that you need to know is that resistance for our purposes in the body and in the field of cardiology in general is primarily dictated by vessel radius and blood viscosity, right? It stands to reason that if you have a narrower vessel, this is a vessel with a smaller radius, it's going to have an increased resistance to flow, right? Also the blood viscosity, right? Remember, viscosity is defined as an intrinsic property of any fluid, and it's the intrinsic property of that fluid to resist flow. In other words, a high viscosity indicates a high resistance to flow, right? In our case, blood viscosity is primarily dictated by, take a moment to pause and guess it, what characteristic of blood dictates viscosity? The answer is hematocrit, right? That's basically the percentage of our blood that's made up of the cellular component, in other words, blood cells, right? And feel free to take a second and think of some pathology that might increase blood viscosity, right? One answer that comes to mind is polycythemia vera, okay? All right, so now this is a good little checkpoint question. All right, which of the following vessels accounts for the greatest drop in blood pressure? Okay, so we have aorta, large arteries, small arteries, arterioles, capillaries, venules, or veins. Feel free to pause the video, and the answer is arterioles. And here's why. So the arterioles, remember, are dubbed our resistance vessels, right? The arterioles are the primary blood vessels that are dictating how much flow is allowed to reach our organs and our tissue beds, right? So let's take a look at these interesting graphs here. Now, I know they're a little bit complicated, but stay with me for a second, right? So our arterioles, remember, are our resistance vessels, right? So let's take a look at our arterioles over here. Note that our arterioles have a relatively low total aggregate cross-sectional area. In other words, if you took all of our arterioles in our entire body and you added them all up and you kind of came up with a number for the total aggregate cross-sectional area of all these vessels, that number is relatively low, right? It's really not that much bigger than like our muscular and elastic arteries, right? On the other hand, if you look at our arterioles, we see that they have a relatively small diameter, right? We see that once we get to the arterioles over here, our elastic arteries have a very large diameter, right? These are things like our aorta, our thoracic and abdominal aorta, very large vessels. But once you get to the arterioles, there's an abrupt decrease in vessel caliber or vessel size, right? So this abrupt decrease in size combined with a relatively low cross-sectional area sets up a recipe for them to be resistance vessels, okay? And if we look at a question that commonly pops into mind is, Chris, but our capillaries are such small, tiny vessels. In fact, they're way tinier than the arterioles, and their diameter is so small, in fact, that barely even one or two blood vessels can fit in the lumen at a single time. Why aren't they our resistance vessels? And the answer to that is because despite our capillaries have the smallest vessel diameter or caliber of any other vessel, they have a relatively large cross-sectional area, right? So this decrease in vessel size is offset by an increase. We see this huge dump in total aggregate cross-sectional area, and that's why our capillaries are not really resistance vessels. So the answer to that question is arterioles. Alrighty, so I know we went through a lot of material there and a lot of different math, but let's bring it back in. So the most important thing that you need to know about blood pressure, the main idea here, is that blood pressure is highly regulated to modify perfusion of body tissue by affecting flow, affecting blood flow, right? And too low blood flow will lead to shock, okay? Remember, shock is bad, right? Shock can be the result of something like hypoperfusion. If you're not getting enough blood to your organs, enough blood and nutrients to your organs, eventually they will start to die and fail. That's shock. It's a state of decompensation. On the other hand, if your blood pressure is too high, this will lead to long-term complications, and this gets a little bit more complex. So here we go, the meat of the lecture. All right, so hypertension is defined by the American College of Cardiology and the American Heart Association as a blood pressure greater than 130, systolic and or diastolic greater than 80, right? And the reason why they came up with this number is they did a ton of different research and a huge amount of literature review looking at different studies, both bench studies and laboratory studies and also clinical trials, which showed that this is a good number for them to basically act as a target or category, right, in which they want to treat. So you want to, ideally a patient will have a blood pressure below 130 over 80, right? That would be considered ideal. And the reason for this is because they came up with all these different studies, right? They looked at things like the Framingham study, which was a study that was done in Massachusetts, I believe. And they looked at, I believe it was over 5,000 patients, and they followed them for decades. And they found that patients with these elevated blood pressures, especially those over 130 over 80, tend to have higher rates of certain complications, right? So a lot of thought went into coming up with this number. All right, so now let's get into why hypertension is bad. And at this point, I invite you to pause the video and kind of write down some disease associations that you remember being associated with hypertension. So we will first discuss left ventricular hypertrophy, right? Left ventricular hypertrophy is essentially a thickening of the walls of the left ventricle of the heart, right? And we'll talk about why that's bad in a second. Now think, if you have high blood pressure, so this means high pressure within our arteries, of course, right? That increases the afterload that the heart must pump against, okay? Think about it this way, right? If we have high pressure in the arteries, the heart must work a little bit harder in order to pump at an adequate pressure in order to overcome that back pressure from the arteries and keep blood moving forward, right? So higher blood pressure leads to a higher afterload that the heart must pump against, and thus a higher intracavitary pressure within the left ventricle, so to speak. And if there's one thing that I want you guys to know about our heart and our cardiomyocytes, those are our heart muscle cells. If there's one thing that I want you guys to know, it's that our cardiomyocytes hate being under tension. Okay, cardiomyocytes hate tension. Now let's take a look at this equation. This right here is Laplace's law, right? It describes the relationship between wall tension, pressure, radius, and wall thickness, right? The idea here is that an increase in transmural pressure is going to result, assuming the radius and the wall thickness stay the same, is going to result in an increase in wall tension. Now, of course, this equation isn't perfect. You know, obviously we're dealing with like something physiologic, and in real life, you know, as something stretches, the walls of the heart must thin, but it's a pretty good model in order to just understand this concept, right? So if we're increasing our pressure and our radius and wall thickness are staying relatively constant for now, this will automatically result in an increase in wall tension, right? Because then we're at the other side of the equation. This makes sense, okay? And remember, our heart muscle cells hate being under tension. So what do? Okay, studies show that just within mere hours, and I'm talking like 3-4 hours of seeing increased tension between the cardiomyocytes and increased pressure, they will already start to transcriptionally upregulate synthesis of actin and myosin filaments. They will then begin to add sarcomeres. These are like the functional units of muscle cells. They will begin to add sarcomeres in parallel, causing the heart muscle to thicken. And again, this starts in just hours of seeing increased pressure and wall tension. It's very incredible. However, it takes a matter of years typically in order for this to have any noticeable effect grossly on the heart. Okay, so now let's get into why is this bad, right? And this gets kind of tricky because we've always been taught that hypertrophy is a good thing, right? So think about, you know, a lot of us Americans like to go to the gym, right? We're taught by our doctors and by the media that, you know, if we're going to the gym, exercising, growing our muscles, that this is a good thing. It's a healthy thing, right? It makes us stronger. It might make us more attractive to some people, and it makes us healthier as well. And this isn't entirely untrue, right? Remember that hypertrophy is just a physiological response to increased functional demand, right? So it would stand to reason that a thicker or stronger heart would be good, but that's actually not the case, right? And the reason is because we deem the hypertrophy that we see in the heart as a pathological or bad kind of hypertrophy. It's not the same as, you know, when you grow your biceps or your quads when you're exercising in the gym. This is bad muscle growth or bad hypertrophy. And the reason is because we see an increased number in the myocytes, right? So as our heart muscle is thickening, of course, we're producing more tissue, more myocytes that can kind of work together with the heart and contract and go through the pumping action, right? But we don't see the same increase in numbers of capillaries, right? So if we're increasing our myocytes and we're increasing the functional demand of our tissue, of course, more myocytes means more energy is required to keep them going. We're increasing our functional demand, but we're not increasing the blood supply to our heart muscle with capillaries, right? So this sets up a literal recipe for ischemia. And that's one of the reasons why people with this thickened heart muscle, people with left ventricular hypertrophy, are more susceptible to heart attacks and ischemia and angina, right? It's because they have an increased number of cardiomyocytes increasing the functional demand of the heart, but they don't have the same increase in blood supply via their coronary vessels and capillaries. All right, this is another good one. So hypertension can cause pathologic changes in blood vessels, namely atherosclerosis, right? Atherosclerosis is very interesting because it's responsible for quite literally like 50% of all mortality in the Western world, right? Think things like stroke, heart attacks, all implicated. Atherosclerosis is implicated in all of those, right? And the thought is that hypertension initiates the endothelial damage that's required in order to be the first step of atherosclerosis, right? Remember, atherosclerosis is the formation of an intimal plaque within a blood vessel wall, right? And then this intimal plaque will kind of grow and expand outward, and what it will do is it will narrow the caliber of the vessel. In other words, if you have this plaque that's attached to the inside of the vessel wall, it narrows the functional diameter of that vessel. This leads that vessel more susceptible to being occluded by something like, let's say, an embolus or a traveling clot, right? This traveling clot comes along and gets lodged in this narrowing vessel. This can result in decreased blood flow distally to that artery. Another thing that can happen is sometimes these plaques can rupture, right? Just because of local turbulent flow and high flow states within an artery, sometimes these plaques can kind of break open, especially if they're fresh or new plaques. And they continuously undergo remodeling. And then what breaking open a plaque will do is it will expose this super nasty necrotic lipid core, right? And this necrotic lipid core is highly coagulable and sticky, and it will result in the formation of a new thrombus, right? And the formation of this new thrombus could actually lead to complete occlusion of the vessel. So you can go from something like here, where maybe you're having 30% occlusion, this plaque ruptures, you form a new thrombus, and then this leads to complete obstruction of the vessel due to the formation of that new thrombus. Also, chronically, if you're having this plaque that's obstructing blood flow, it results in chronically reduced blood flow to distal tissue sites. This is called peripheral artery disease, right? Let's say you have arteries in your legs that have a lot of plaques in them. This will ultimately lead to the long-term reduced flow of blood vessels to your legs. And that's why people with peripheral artery disease often complain of claudication. That's the painful feeling in your legs that you feel sometimes when you're walking great distances. This is because the arteries can't compensate for the increased demand of your leg muscles and your leg tissue when you're walking or exercising, right? So that's peripheral artery disease. It's caused by atherosclerosis. And hypertension is the initiator of all of this. Why? Because of endothelial damage. All right, the next thing, hypertension can also cause pathological changes in relatively smaller vessels. Remember, atherosclerosis is a medium and large vessel disease. It doesn't typically happen in smaller vessels and capillaries, although it can sometimes, and we'll get to that. But anyway, hypertension causes a process called arteriolosclerosis, right? And this is characterized by thickening and hardening of our arterioles. And this results in decreased blood flow and weaker vessels, right? And the mechanism for this is that hypertension induces increased plasma protein leakage across endothelial cells. And then this also upregulates smooth muscle cell matrix synthesis, right? So the smooth muscle cells will begin synthesizing ECM, right? This is basically connective tissue components, and these will build up within the vessel wall, causing the vessels to become a little bit more fragile and also narrower, right? I love this diagram here. We can kind of see the difference between this normal vessel here and then this vessel that has undergone hyaline arteriolosclerosis, right? It's more fragile and it's more narrow, right? And then this can cause problems in so many different areas of the body, right? So let's start with the kidneys. If you have arteriolosclerosis in arterioles of the kidneys, right, that means the arterioles are becoming harder and narrower. This will result in long-term chronically decreased blood flow to the kidney tissue. Over time, this will result in scarring and fibrosis of the kidney tissue, leading to less functional kidney tissue being available to do its job, which is, of course, to, quote, filter the blood. Really, it has to do with just maintaining ion balance. That's kind of the most important function of the kidney, to maintain ion balances and proper levels of ions in the blood, and to excrete certain ions that are in excess into the urine, right? And if the kidney is not able to do its job, then that leaves us vulnerable to a process called kidney failure, of course, in which the kidney is not able to properly regulate these ion levels. And of course, that's bad for homeostasis, right? Another thing, in the brain, this one's really cool. So in the brain, you basically get this hyaline arteriolosclerosis as well, right? We talked about how these vessels are more friable or fragile, right? These vessels in the brain can then basically burst, right? That results in a hemorrhagic stroke. Remember, this is bad because if a vessel bursts, obviously then you can't supply blood to the distal sites that that vessel was previously supplying. And it can also cause the blood itself in the brain can also cause a mass effect, or basically an increased pressure that results in putting pressure on other structures in the brain. This is bad because if you're putting pressure on other structures of the brain, it can cause impaired function of those structures and even cause them to herniate or move to a place that they're not supposed to be. Okay, and in the retina, this is probably maybe one of my most favorite ones. So hypertension in retinal vessels can result in retinal vascular disease, and there's a whole bunch of different changes that you might see in retinal vessels, but we're just going to talk about probably my favorite one. Okay, so let's describe this here. So our retina is actually unique because our venules and our arterioles in the retina share an adventitial sheath, and they travel really close together. And this is kind of a characteristic that's seen mainly in the retina, but also in a few different other places in the body. But interestingly, when our arterioles in the retina are becoming kind of thick and sclerotic, like this vessel here, okay, this can lead to this basically an increased tension on the adventitial sheath. Remember, the adventitia is this kind of supportive connective tissue that surrounds and wraps blood vessels, right? And remember, the venules and the arterioles in the retina are sharing the sheath. So if we're putting increased tension on this sheath and stretching it out, this will result in compression of the lower pressure venial system, right? So the sheath is stretching and then it causes compression of the venules. This will result in venous stasis, right? So the venous blood will no longer be able to flow or drain. And then this is a problem because stasis is a recipe for thrombosis, right? Then you get the formation of a clot within the venule, and then that will cause downstream basically blockage of the venous blood flow. And that's just one of many different changes that you can see within the retinal vessels. All right, and there's many more different complications that we won't discuss in detail today. So we already discussed hypertrophic cardiomyopathy, dilated cardiomyopathy. That can be a lecture, and CHF. Those can be lectures in and of themselves, right? Atrial fibrillation, this is actually a pretty good one real quick. So I think hypertension, right? You increase the pressures that you see within the cavities of the heart. That kind of is somewhat intuitive, right? So you have think we have our left atrium, right? So increased pressure and the increased pressure of the blood will lead to kind of stretching and increased pressure within the left atrium, right? The left atrium does not like to be stretched. Okay, stretching will result in local damage, microtrauma, and also fibrosis. And remember, the atria of the heart is very important in conducting electrical signals that regulate heartbeats. Okay, so if we're having upset electrical pathways within the atria, this can result in basically generation of new automaticity foci within the atria, and then you get these different firing of all these different foci of automaticity within the atria and leads to this chaotic beat that we dub atrial fibrillation, right? So hypertension leads to stretching and fibrosis of the atria of the heart, and then this leads to disordered electrical signaling, and that causes heart arrhythmias, okay? And arrhythmias are bad. Next, aortic aneurysm. That's also a very interesting one. So aortic aneurysm is a focal dilatation of the aorta, so it's becoming bigger. It's a balloon-like dilatation, and typically it's seen in the abdominal aorta. Okay, and the reason for this is mainly due to atherosclerosis, right? So the abdominal aorta is a perfect place for atherosclerosis, and the reason for that is multifold. So first of all, it's a large vessel. Remember, atherosclerosis is a large vessel disease. Okay, the other thing to keep in mind is that the abdominal aorta lies right above bifurcation. The abdominal aorta bifurcates into the right and left common iliac arteries, right? Bifurcations are common sites of turbulence within our blood vessels. Turbulent blood flow is kind of chaotic, swirling flow. It's not the organized laminar flow that we like to see in our blood vessels. So at branch points, we can commonly see turbulence. And turbulence is a nice setup for atherosclerosis. For some reason, atherosclerotic plaques and clots love to form in sites of turbulent blood flow, right? So hypertension is initiating this endothelial damage that you typically see as the first step of atherosclerosis. Okay, this will happen in the abdominal aorta for the reasons that we just discussed. This atherosclerosis in the abdominal aorta, so the buildup of these plaques within the intima, will lead to impaired diffusion of nutrients through the blood vessel walls. If we have impaired diffusion of nutrients through the blood vessel walls, this will result in weakening and ultimate degeneration of those walls. A weaker wall is more prone to being blown up because it can't really kind of maintain its composure against this increased pressure, and it will slowly blow up and dilate. And eventually, if these become bad enough, they can rupture and they can cause problems. So that's how hypertension causes abdominal aortic aneurysm. Okay, it initiates the endothelial damage necessary to build up atherosclerotic plaque. Okay, aortic dissection, that's another good one. Hypertension accelerates the cystic medial necrosis. That's typically a big factor. And also intimal damage. That's a big factor in aortic dissection. Or the formation of a false lumen for blood to kind of conduct through within a vessel wall. Carotid artery stenosis via atherosclerosis, and many more complications. So now let's talk about how blood pressure is measured in a clinical setting, right? Right here we have the sphygmomanometer, and that's a medical device that is used for non-invasive blood pressure monitoring. So let's talk about how this works. So the cuff is placed around the arm with the lower end of the cuff roughly at heart level. And the reason for that is because the most clinically useful blood pressure value is the value that is most similar to the value that you'd expect to be seen in a heart. So, if you look at our arm, the arm is, if you put the cuff here, it's at roughly the same level that we'd expect the heart, right? That's why a blood pressure value taken at like the thigh or other locations would be a little less clinically useful, right? So then what you do is you inflate the blood pressure cuff to cut off all flow through the brachial artery, right? And we see a good picture of that right here. So it stands to reason that if there is no blood flow going through the brachial artery, if you auscultate that artery, you're not going to hear any noise, right? That's rather intuitive. Then what you do is you slowly release the blood pressure cuff. And then as you slowly release the blood pressure cuff, eventually the pressure within the cuff will drop below the systolic or highest pressure that you see within the artery, right? And then as you drop below this systolic value, at some points within the pulsatile cycle of blood flow, enough blood flow would be able to just kind of barely squeeze through, and we can kind of see that here. Just at some points within this pulsatile cycle, enough blood flow is barely squeaking through. At the same time, keep in mind that this cuff is disrupting the local architecture of that vessel, right? It's kind of squeezing this vessel, resulting in kind of chaotic squirting, swirling blood flow occasionally at different times during this pulsatile cycle, right? We can kind of see a picture of that here, this kind of compressed, unhappy artery. Over here we have our nice, neat laminar flow, and then eventually it kind of comes up on this stenotic portion, And then that laminar flow turns into turbulent flow. Turbulent flow is characterized by this chaotic swirling movement. And as this blood is bumping up against the vessel walls, because remember in turbulent flow, normally the blood flow velocity close to the vessel, in laminar flow, normally the blood velocity within the vessel will be close to zero, right, at the edge of near the wall. And then whereas in the middle, that's where you get your kind of peak velocity, right? On the other hand here, you're getting over here turbulent flow, where blood is kind of swirling and bumping into the walls. And then this swirling bumping creates sound, right? And those sounds are dubbed Korotkov sounds. So that's why when you deflate your blood pressure cuff below the systolic pressure, you will begin to hear Korotkov sounds. Okay, that's the bump, bump, bump that you auscultate as the blood pressure cuff kind of begins to lower its pressure. Next, eventually, you'll lower your pressure below the diastolic pressure, or the lowest pressure that you can see at any point during the pulsatile cycle of an artery. Okay, once you're below the diastolic pressure, the artery will no longer be deformed at any point within the pulsatile cycle. At this point, the laminar flow will be completely restored. And since the laminar flow is restored and the turbulent flow has disappeared, you will no longer hear Korotkov sounds, right? So that's why we are able to estimate the blood pressure using this cuff by listening to Korotkov sounds happening between the systolic and the diastolic pressure. And then typically you record the value when the sounds start as your systolic pressure and when they end as your diastolic pressure. All right, so next, ensuring proper technique is critical for measuring blood pressure because you want to make sure you get an accurate value, right? First, you want to make sure that there's a quiet exam room, right? Korotkov sounds are relatively quiet, and you want to make sure that you're able to hear them, right? So it's not a good idea to have loud music and talking in the background while you're taking the blood pressure. Make sure that the temperature within the office is comfortable. Definitely avoid cold. Make sure that AC isn't blasting because cold will actually cause the patient's blood pressure to increase, right? So make sure that the exam room is comfortable. Make sure the patient is seated with their back supported and legs uncrossed, right? This is actually critical. Okay, think, what can leg crossing do to your blood vessels? Feel free to pause the video and kind of take a guess. This is a cool one. It actually does two things. First of all, leg crossing will, of course, locally deform different arteries within your veins, and then this can increase those arteries' resistance to flow. The other thing that it can do is it can compress those superficial veins that you have in your thighs. Remember, we have that muscle pump action within our legs, right? Remember, the act of our muscles just contracting will ultimately result in compression of veins within the legs. And remember that veins are a relatively low pressure system. And then that this compression of our veins will allow the blood to kind of shoot up from our veins, right? And allow venous return to the heart. So if we're compressing those superficial veins within our thighs by crossing our legs, we're increasing the venous return to our heart. This will then increase our stroke volume while we're taking the blood pressure, and it can cause an artificial increase in blood pressure reading. I think typically it can be up to 8 to 10 millimeters of mercury, right? Increasing you 8 to 10. That's actually pretty big, and so you want to make sure you're avoiding leg crossing while taking the blood pressure. Also, avoid smoking, caffeine, and exercise for 30 minutes prior to measuring the blood pressure. This is actually a rule that a lot of different offices break. A lot of times, like the first thing you do if you walk into the ED or into a doctor's office is they sit you down, and within 1 minute they already have your blood pressure taken, right? Technically, you're not supposed to do that. And this is because smoking, caffeine, and exercise are all things that will increase your blood pressure, right? So ideally, you want your patient to be sitting down and relaxing and not moving too much for almost 30 minutes, right? Almost typically, I mean, a better, more reasonable goal is like closer to 10 minutes, but ideally 30 minutes before you're trying to measure their blood pressure if you want to get an accurate reading. I'll never forget one day when I went to the Student Health Center at my undergraduate institution at Rowan, and luckily they had very good staff there, and but they made the mistake that everyone makes, which is right when I walked in for my appointment, they the first thing that they did was took my blood pressure within just like 2 minutes of sitting down. And I remember they were very concerned that my blood pressure, the systolic, was in like the 150s or maybe even low 160s. But so at first they were like very concerned. But it was funny, what I failed to mention to them was that I happened to sleep in that day and I was late to my appointment, so I ran all the way from my dormitory to the student health clinic. Okay, by the time I got there, I was, sweating. It was like an 85-degree day. I had run the whole entire way, so I was exercising. On top of that, I think out the door, I had grabbed like a 5-hour energy or some sort of energy drink, and I like chugged that. So that probably also raised my blood pressure. So these are all things, when you see a patient with a higher blood pressure than you would expect, it's important to ask them if they, recently smoked, consumed energy drinks, or exercised prior to the reading. Next, you want to ensure proper cuff size, right? If you use a cuff that's too small on someone like a bodybuilder or someone with big arms, it will result in an artificially high reading. If you use a cuff that is too large on a more petite or smaller person, this will result in an artificially low reading. All right, with that said, that concludes this presentation. I love giving this presentation. It's even better live because then I'm able to kind of ask the audience questions. I like to crack jokes during the presentation too, so it's a really good time. And if anyone wants to reach out and have me give this presentation live to someone who's local or maybe via like WebEx or some sort of online platform, I'd be happy to do this because I think blood pressure is a super important concept to understand, and unfortunately not enough people explain the pathomechanisms of why hypertension is important to treat. So hope you guys enjoyed. Thank you.